you. I think just as Dr. Kali said, we know affordability is a big issue. And in fact, KHRC, our motto is research to policies. So we are always mindful of the fact that our research should make impact. And also the question that you just talked about has come up. And we've tried to do a lot of work in this area to ensure that at the end of the day, the question of affordability is taken care of. So, in fact, just this January, at the tail end, we are launching what we call Gas Pay. So Gas Pay here is a digital platform. Over the years, what we've learned is that, gas, yes, we are encouraging people to use. So we've looked at the expenditure households spend on gas, and then also on charcoal especially. And we've seen that there is no significant difference between these two. So the difference or the challenge we find there is the liquidity. Charcoal, you can take 1 cedi to go and buy charcoal just at the corner. So with the gas pay intervention, we can provide the LPG for you. Of course, we are linking up with LPG marketing companies, and in this case, to ensure that, and then we've also engaged ZPay, and then we've also engaged Rancard. These are ZPay. I'm sure those of us in Ghana and probably across Africa, we are aware about ZPay. So they are able to give us the electronic money platform. And then we have Rancard also having the capacity to kind of link, the background or the IT stuff. So what we are doing innovatively is that we can, through the gas pay intervention, we can make the LPG available through the LPG marketer. And then the consumer takes time to pay over time. Or the other option is that the consumer could make some savings towards buying the LPG. And we've done this mindful of the fact that, as I earlier mentioned, we don't really find significant difference between the amount of money at the end of the month that they are spending on charcoal as compared to LPGs. And we believe this intervention can also help. There are others, but probably we can talk about it over tea or some other time.
Thank you very much. I'm wondering whether we should always be talking about LPG. Because LPG prices will never come down. It will always go up. And I think there are other better options. I know in East Africa, they are trying to convert waste into biogas, which waste is available everywhere in the country. So I think we should be looking for, to other better options, cheaper, of course. I think that's, in my opinion, might be the way. Because LPG prices will never come down, apart from the erratic supply. Thank you.
Okay, thank you very much for that. Yeah, I think the future is to have a mix of options, right? Energy options. So people who can afford LPG, and by using some of these methods that Dr. Suleimana just described, in Nigeria, there have been studies on ethanol cook stoves as well. So there are different options that we can have for the future. But we are just showing the potential health benefits that we can derive from clean fuels for household purposes.
Okay, Dr. Kali, thank you very much for your presentation. My first question is, during your study, did you encounter some challenges to the use of the gas stove? Because we did some community engagement in one of the low-income areas in Accra, and most of the folks there were apprehensive about using the gas. Some said due to cultural reasons, they preferred using charcoal because that's what they grew up with. Their grandmothers and mothers were using that. And in some of the communities there also, they said that because they are, tenants, the landlords had advised them not to use the gas because they had seen some homes, what the gas have done by burning down some of the homes. So they were told directly not to use the gas. I don't know whether you came across any of these. That's the first point. The second point goes to your intervention. I think in one of the slides you showed that your intervention was to give a certain cohort the gas, and another one was using the traditional one, right? Now, I'm curious to know whether you also, how did you handle the issue where in the same compound house, one is using the gas and another one is using the biomass? How would you reconcile this? Because the exposure may be encountered by both of them. I don't know whether you came across such a situation. How did you handle it? Thank you.
Okay. So thank you very much for your for your questions. Yeah. So in terms of challenges in using the LPG, so we didn't come across situations where household heads or the house owners did not allow for the use of the LPGs, because this was a controlled study, right? So we had to make sure that we had done our community engagement, involved the household heads and all that to buy in. And we didn't encounter any situation where there were accidents or burns from use of the LPG. In fact, we have an analysis that shows that burns from cooking was much lower, in the LPG arm compared to the control arm. So that's another benefit. But because of engagement, community engagement activities, the LPG was well received. And when we finished the study, we had to make sure that we also gave the LPG stoves and cylinders to the control arm, those who did not receive the BioLite, the improved biomass, and then the control arm. People liked to use it, but then it in terms of sustainable use and long-term use and refill of the gas and all that, it comes down to economic reasons. Yeah. And the second question, the intervention. Yes, exactly. Yeah. So as we showed, our analysis on the effect of the interventions on air pollution. So for both, for CO and PM2.5, the effects were moderate, right? Because we acknowledge that this wasn't a compound or household-wide intervention or a village-wide intervention. So there will be some household members or households within a compound using the intervention and others using the traditional stoves. Yeah. We think that that's one of the reasons why the intervention did not achieve a high level of exposure reduction, as it was only 47% reduction in CO. Yeah, and so that probably also accounts for why we did not see any effects of the intervention on the health outcomes, because the exposures weren't reduced enough to see health impacts of the intervention. But we show health impacts when we did exposure response analysis.
Thank you for this wonderful presentation. Since it's a control study, I'm wondering whether you mentioned it in the course of your presentation, how you were able to control external influence of pollutants in the study groups. Because I suppose that if you were able to control the sources of pollution in terms of cooking, you will have external influences of pollutants getting into that same environment. We're able to control that to ensure that your targets are only influenced by the source of cooking as a source of pollution.
Yeah, thank you very much. So I think this question also relates to the question that Dr. Hughes just asked, right? So we were not able to control for that because this was a household level intervention. This was not a community-wide intervention. So there were other sources of pollution from other household members that were using polluting stoves, and then also from other sources like refuse burning, like mosquito coil burning, and all. So in our models, we adjusted for these. We adjusted for other environmental sources of air pollution. We adjusted for secondhand smoke exposure, smoking, tobacco smoking exposure, because these were non-smoking pregnant women that we recruited. So because of the nature of the study, we couldn't control for these, but then we adjusted for these variables in the analysis. Yeah, I think Steve has something to add.
So yeah, no, I mean, we've always used that same thought. In fact, the very first time I walked through one of these communities and saw how densely populated they were, especially in the compounds, where there might be 4 families cooking within a few meters of each other, I didn't think we would drive the exposure down that low with the LPG, and indeed we didn't. However, the Happen trial, which happened after us, did get really large exposure reductions, and yet their intention to treat analysis was also negative. They did not see an impact. And all the WASH randomized controlled trials, washing your hands, which we all know is a good thing to do, are all negative. So do you have any, I'm getting sick of randomized controlled trials always being negative. The fact that our year 4 lung function on an intention to treat analysis is positive is really exciting. It's not a perfectly randomized controlled trial anymore. But it's still exciting. But what do you think is wrong with randomized controlled trials where you do get the reduction in exposure, but you still don't see an effect, like in the Happen trials and in the WASH? And this is more of a philosophical statement.
Yeah, I don't think there's anything wrong with these trials, with randomized controlled trials. But, I mean, there might be something to do with the timing of the interventions. So